Dear students, we are starting our first lecture this semester, the 8th in a row, which is devoted to the wound process, that is, the wound, the definition of the concept of wounds, the classification of wounds, the pathogenesis of the wound process itself, the general local manifestation and, in particular, first aid and wound treatment. Also, a little attention will be paid to such a formidable moment as a mine explosion injury, and, accordingly, the injuries received during it. So, what is the concept of a wound? A wound is tissue damage with a violation of the integrity of the integument, whether it is the skin or the mucous membrane, and also often with damage to underlying tissues and organs, which can be caused, that is, the wound itself, or by physical, mechanical influences. Well, in this case, there is an option of obtaining chemical damage. These are so-called chemical burns. The physical methods of exposure include ionizing radiation energy. But in most cases, wounds are still obtained by mechanical action on the body. This slide shows the anatomy, that is, the pathological anatomy or morphology of the wound itself. That is, each wound has an entrance hole or, as it is called, a wound gate. The wound itself has edges on the skin or on the mucous membranes. The wound has walls, the bottom of the wound. If we have a through wound, there will be such a classification, then there is an exit hole. The next moment, there is an understanding inside the wound itself, the contents of the wound. This may include destroyed tissues and folk bodies, blood clots, in particular, yes, microbial handicap, Wundsudat. If the wound is received as a result of exposure to high energy, say, exposure. Well, in particular, here you see, in the illustration there is, that is, say, a scheme such that the wound was inflicted by a firearm, then there is still a so-called contusion zone around the wound, or a bruising zone, as it was previously called. And if we consider this from the perspective of pathomorphology, then this is a site of necrotic tissues. Those same necrotic tissues that were affected due to the high energy available to the wounding projectiles that died in the process of injury. Behind this zone there is still a zone of emotions or a zone of concussion. This is also typical only for a gunshot wound. In this case, if we consider pathomorphology, this is a necrobiosis zone. That is, the tissues are in a state of functional impairment. They can essentially survive, but they can also die. Classification of wounds. Quite an interesting detailed classification of wounds by the nature of the wounding weapon. Let's take a closer look at each of these points. So, a cut wound. A cut wound is inflicted with a sharp instrument, for example, a sharpened knife, a scalpel, or a sharp edge of broken glass or ceramics, and in this case, most often, the early projectile itself moves parallel to the surface of the skin. Due to the fact that it is sharpened, it cuts the skin. The incised wound is characterized by smooth edges, smooth wound surface. She has a slight gaping, but at the same time there are features such that this wound often bleeds heavily. This is explained by the fact that the mechanism itself, a sharpened projectile, cuts the skin. In this case it can easily damage even the arterial wall in this way. That is, if we take, say, a bruised wound, then the arterial wall is a very durable object. Well, in this way you can damage it quite simply. Again, due to the fact that the mechanism of receiving such a sharp projectile, the pain is often insignificant and weakens quickly enough. The specifics of providing assistance in this case are based on this. It is not always early to require powerful anesthesia, but at the same time it requires mandatory benefits due to the fact that the edges of the wound, that is, it gapes early due to the fact that it is open. Wounds require mandatory monitoring of it in terms of damage to the main, or large vessels. That is, the wound can hurt a lot. The next variant of the wound is a chopped wound. Chopped, but the wound is applied most often with an axe, a saber, a machete. It is quite close in appearance to the cut, but there is such a situation that in this case the wounding weapon has a sufficiently powerful kinetic energy and it is quite possible that the chopped wound will be very deep. That is, in the presence of the fact that visually it looks very similar, but in depth it is much larger than a cut wound. Due to the fact that kinetic energy in the process of how the projectile stops in the tissues earlier is transferred to the tissue, a sufficiently large volume of it goes into nearby tissues and nearby tissues are damaged. Most often, blood vessels are damaged. The walls of the wound soaked in blood can be crushed. In the depth of the wound, due to the fact that the wound is very deep, the underlying organs and tissues may be damaged. In particular, there may be fractures of the bones of the extremities, and very often with chopped wounds there are injuries to the tendon apparatus, that is, in essence, a very strong structure in the body. The pain in this case is most often significant in terms of first aid. If we said that incised wounds may not require strong anesthesia, but they must be monitored for bleeding. So, in terms of first aid, chopped wounds very often require immobilization in addition to anesthesia. Yes, especially if we actually observe damage to the tendon ligamentous apparatus or the bone apparatus. Stab wounds. Stab wounds are inflicted with a stabbing weapon. Well, the most common is an awl, a bayonet, a nail. If we take, let's say, the times of the Middle Ages, this is a rapier, that is, there was a special piercing weapon. The areas of damage, most often the tissues are small, the edges of the wound are compressed and bleeding is most often external is not observed. If damaged, sufficiently powerful hematomas can form there in the depth of large vessels. The pain is insignificant due to the fact that a small amount of altered, that is, destroyed tissues. But there are certain features here specifically for the cut wound. If the wound is inflicted in the projection of vital organs of the systems, for example, the abdomen, chest, and at the same time, the wounding weapon we have with you is quite long, there is a risk of penetrating injury. Not only is there a wound penetrating into the cavity, but also a wound with damage to internal organs, which we cannot visually determine at the stage of first aid. The conclusion is that stab wounds are extremely dangerous. If we really observe a wounding weapon in the form of a button, let's say, and a cat and early on the ass, well, there is no fear here. If we suddenly see a cut at the wound in the abdominal wall and at the same time a wounding weapon, for example, a screwdriver is long enough, then there is a risk of damage to internal organs and hence, in terms of first aid, the point should be clearly formulated that the patient should be referred to competent professional doctors, that is, a surgeon if this is the abdominal cavity, to the chief surgeon, yes. If it is the retroperitoneal space, well, the lumbar zone, then perhaps to the urologist to assess the integrity of the subject organs. Another feature of the coat of Iran is that due to the fact that the exit opening is extremely small, that is, the entrance, yes, and you and I cannot observe in the depth of the wound, it is quite difficult to review. And there is another charm. At the initial stages of first aid for stab wounds, alcohol-containing antiseptics can be used as, say, antiseptics. For other types of RA, an alcohol-containing antiseptic is not a closed, not sutured wound, but this is, at least, a very powerful pain component and, at most, it is also tissue coagulation due to the effects of alcohol. For stab wounds, alcohol can most often be used at the pre-hospital stage. The next most common type of injury is probably bruised wounds. Well, in this case, even the impact of the most wounding projectile is not necessary. Very often, a person himself falls and bruises himself on solid ground, well, or into some solid objects. Wounds. One of the variants of a bruised wound is the so-called decomposed wound. That is, when there is a dense formation under the soft damaged integumentary tissues, for example, bone. And as a result, there is, as it were, a pressure between the bone and the radiating surface, that is, solid. In the final we have reproduction. Wounds. The degree of damage depends on many factors, on the force of the impact, on the nature of the damaging agent. Most often, the edges are bruised or multiplied, especially the wounds are uneven. There is little bleeding. This can be attributed to the fact that the edges of the vascular wall are squeezed and as a result, as such, external bleeding is small. But if parenchymal organs are damaged in the depth of the wound, then the bleeding can be very serious. That is, in this case, a bruised wound and as such, as it were, a closed injury to the underlying organs and tissues, that is, polychymatous organs. Bruised wounds are quite painful. They have a certain peculiarity and difficulties in terms of treatment. Most often, the surface around the wound has sedimentation, so we will analyze different methods of closing, that is, they are quite well sutured. Well, perhaps there are difficulties only with restoring the cosmetic correctness of the surface tissues, but at the same time they are very unsuccessful in terms of using an adhesive form of fixation. That is, adhesive plasters or modern various adhesive systems. Unfortunately, the adhesive plaster does not stick to the besieged surface. Plus, bruised wounds are quite common due to the peculiarities of blood supply, and they inflame the wound walls very often. Well, plus they pollute themselves quite seriously. Wounds of uneven, say, configuration, have different, say, pockets and so on. Bruised wounds often leave behind unpleasant cosmetic consequences of evil, for example, cut wounds, well, especially puncture wounds. The next item in the classification, I'll start at this wedding from the bottom, the bitten wounds. Wounds arise as a result of a human bite by an animal, and in this case there are certain features, yes, that is, most often the form of the wound can be of a ragged nature. Now we will talk about it, if the animals are large enough, massive, or if the animal is small, and his teeth are small, the wounds may represent a kind of puncture wound. But there is a certain peculiarity in terms of infectious consequences or allergic effects of exposure. Who bit? If we have a bite by a warm-blooded animal, then in this case we have a certain suspicion of rabies infection, that is, a variant of virulence of wound infection. And besides, given that animals do not brush their teeth, boards and wounds are often complicated by classically banal inflammation in the form of suppuration of the wound, in the form of phlegmon formation in depth, and so on. If the wound is not inflicted on warm-blooded animals, then, for example, reptiles, yes, that is, a sufficiently large volume of reptiles are poisonous, and the effect of such, in this case, poison on a person can have far-reaching consequences, up to a fatal outcome. If we have bitten wounds that are inflicted by arthropods, then most arthropods, whether insects or arachnids, can also, at least, cause an allergic reaction, as a maximum, have their own sufficiently powerful poison. Here it is necessary to approach it in this way. Lacerations. Lacerations are formed due to the tension of the integumentary tissues. That is, the wounded projectile also moves, as well as the previously cut parallel to our body surface, but at the same time it is not so smooth and sharpened. It has protruding edges. Well, let's say a saw is drawn here in the illustration. Imagine that a saw catches pieces of leather with its pointed edges and begins to pull them aside. In this case, as a result of the tension of the integumentary tissues, skin fragments are torn off from the underlying, yes, that is, the epidermis is torn off from the underlying dermis. As a result, we have areas of skin that have impaired nutrition due to damage to the underlying vessels. With further shifting, yes, there is an option not just to tear the surface of our integumentary tissues, that is, skin or mucous membranes, but to tear out a fragment altogether. Yes, and in this case we will have a defect of the integumentary tissues. Such a wound will be called scalped in our country. With such wounds, there is often quite a powerful soreness and the wounds bleed significantly. Given the fact that nutrition is disrupted in some fragments of soft tissues, these wounds very often require serious such operations for the transplantation of integumentary tissues, that is, skin plastic surgery, for example. Well, we got close to the final, to one of the most unpleasant types of wounds, probably, depending on the effect of the wounding weapon, to gunshot wounds. That is, gunshot wounds are caused by the action of firearms, whether it is a bullet as a result of a bullet hit, yes, fragmentation or buckshot, or a mine explosive wound, in which, say, the earliest weapon is as such a mine or a grenade. Such wounds, due to the fact that an early projectile has a very powerful kinetic energy, can often be through, although there are classifications in which they are both blind and tangential. Do not forget that there are ricochet wounds. If we take a closer look at this subclassification inside a gunshot wound, then we have a through wound with an inlet and outlet. We have a blind wound, say, only an entrance hole, and in the depth we have a wounding projectile, with a through wound from whom there is no projectile wound in the depth. Tangential wound, yes, in this case it does not have an inlet-outlet. Most often there is a longitudinal wound on the surface of our integumentary tissues, well, by the type of such a large powerful abrasion. And ricochet wounds that many do not understand. That is, early in the depth of which, it is at the bottom of the wound that there are dent formations, but most often it is bone. Yes, and the shell is wounded, well, let's call it a bullet, hitting this bone and ricochets and bounces. If he comes out with you and me through the same hole through which I entered, then there will be such a small casuistry. That is, there is an entrance hole, yes, in fact there is no exit. We will consider it early and blind, but we do not have a wounding projectile at the bottom. The search for a wounding projectile in the process of foe can be very much delayed. The clue is that there are dense bone formations at the bottom of the wound and the wound may be a ricochet. Well, let's talk about the features of a gunshot wound at the end of our lecture. Another option for classifying wounds according to the degree of bacterial contamination. Now we will analyze with you the classification, which in fact differs a little from the clinical views on the name of the wound. But remember, this is necessary. So, wounds can be aseptically, that is, inflicted in sterile conditions, for example, an operating room. In this case, the injuring projectile is sterilized, treated in a special way, there is no microbial form on it, and at the same time, the skin itself is treated in a special way. You remember that a fairly large number of saprophytic handicaps live on the skin, that is, the handicaps of our symbionts, those microorganisms that exist and live directly with us on our skin surface. Many of them are conditionally pathogenic microorganisms and under conditions favorable for the rebirth of, say, our addictions. When we inflict a wound, even conditionally pathogenic flora can become pathogenic after some time and cause infectious cooling in you and me. So, under aseptic conditions, the skin is treated so qualitatively that the place that we have as a wound, it is also sterile as a result. The next option, let me skip, is a contaminated wound, when as a result of conditionally clean operations, that is, we are going to inflict an aseptic wound with you. Yes, after all, microorganisms get into the wound. Most often, either because of the fact that, say, a wounding projectile, that is, a scalpel, is poorly treated, or because the skin is poorly treated, or as a result of the fact that in the course of our surgical actions with you, we found foci of infection inside our body and, without noticing them, hid them, for example, with acute appendicitis, and in this case, the wound will be contaminated. Infected wounds. Well, they include the largest number of all wounds that are inflicted on the body, and in this case they are all accidental wounds. The cause of infection in the wound, we analyzed 3 minutes ago literally. This is the presence of our saprophytic form on the surface of the skin. That is, no matter what kind of wound, an infection gets into the wound anyway. And here we begin, in this case, to consider this purely microbiologically correct classification in relation to the clinic in a different way, because in clinical surgery, the infected is not the wound that the infection is, yes, but the wound that this infection has already somehow manifested itself. Yes, that is, in this case, the wound is in the initial stage of any infectious complications. That is, to the wall of the wound, for example, edematous wounds begin to take the form of a hyperemic wound, and we can even assume that for some initial phenomena, for example, serous exudations begin. and it is precisely such wounds in the clinic that are commonly called infected, but in fact, there is an infection in those wounds that visually seem clean to us. Let's say a cut wound that is inflicted with a relatively clean kitchen knife. We will treat the wound with antiseptics in the faux process. We will destroy the flora, plus, our body additionally, yes, in terms of its available protective forces, also destroy a small amount of saprophytic flora that got inside, and there will be no inflammation. But if inflammation occurs, then we can get a wound in the final. Yes, in this case, not just infected, but one that, say, was complicated by infectious diseases. The most frequent, in 99% of cases, is still a purulent inflammatory handicap that develops in a wound, and such a wound is called purulent. We have a clear exudation in the wound, which has a purulent character, that is, purulent exudate. Although no one rules out that there may be, for example, a specific infection to develop earlier, and we will talk about this at our last lecture with you this semester. Well, pay attention. An aseptic wound on the left, a neatly overlaid surgical field, treated, and here is a purulent option early with an abundance of necrotic tissues and a purulent flow directly from the wound. In relation to the internal authorities, wounds are divided into penetrating and non-penetrating into the cavity. If we consider all these aspects of classifications and put them together, then you and I will get a diagnosis in metal that will sound, well, let's say, an infected incised wound there of the right upper limb. Yes, or there is a wound of the anterior abdominal wall penetrating into the abdominal cavity. That is, all these classification options assume the correct name of the wound when forming a diagnosis. The biology of the wound process, well, or pathomorphology, that is, we have several phases early in the process of our, say, existence. And the first phase is the phase of inflammation. Moreover, you need to immediately understand that in this case we are not referring to inflammation caused by microflora that has developed in the wound, but such inflammation is also possible. We were just talking there about purulent wounds, infected wounds, namely, the aseptic nature of inflammation as a result of our mechanical action. We are talking about mechanically obtained wounds on the integumentary tissues. The destruction of the blood tissues occurs, and in the final we, well, let's say, damage the skin. Plus, the vessels that feed this zone are damaged. Yes, as a consequence, there is a spasm, that is, a short-term vascular spasm. This reaction is absolutely legitimate, because any wound is a painful component, which is accompanied by nervous impulses, in which then we receive an answer in the form of short-term spasms and the release of biologically active substances, well, in particular, various catecholamines. That is, biological substances are released. All this leads to a short-term spasm at first, then to a persistent cut of the smooth muscles that regulate vascular tone of the vessels. Plus, in the area of the surrounding wound, as a result of a persistent cut of this smooth musculature, as a result of a violation of blood flow in the microcirculatory bed, permeability begins to increase, it begins to swell early. Yes, the liquid fraction begins to leave the vascular bed into the tissue space. This is also facilitated by the fact that the altered destroyed tissues, well, say, from the destroyed cells, a large number of biologically, let's say, low molecular components, various ions that were contained inside, and that increases the asthmatic, say, they have asthmatic components to their own pressure and attract water, and a large number of large molecular fractions that fall into the interstitial space pull water on themselves. But as a result of this, the walls of the wound swell, blood thickening occurs inside the vascular bed, that is, capillary thrombosis. On the one hand, this formation of tropes are positive components. If the vessel is wounded, then thrombosis is a protective reaction that allows you to stop bleeding. But at the same time, a violation of the blood flow of the vessels leads to the fact that those areas of our soft tissues that should have been, say, supplied with blood by this vessel and begin to experience a very serious lack of oxygen supply. As a consequence, let's say, an inefficient way of energy production with a predominance of anaerobic glucose, acidosis, electrolyte disorders. Yes, again, this contributes to the hydration of tissues again, but in response to such a moment of the presence of late-rated destroyed areas of our body, leukocyte infiltration begins. That is, we ran through almost all the components of inflammation that can be here, plus described the phenomena that lead to this, well, let's say, happened. We have, yes, in this case, inflammation of an aseptic nature. It usually lasts from 1 to 5 days. The next, yes, moment, what's going on? We talked about the migration of the leukocyte germ towards the wound itself. Yes, that is, neutrophils migrate most often on the first day. We have phagocytosis phenomena in the wound area. Yes, that is, we perform destruction and, say, our leukocytes by neutrophils absorb the destroyed cells, that is, non-cellular proteolysis. A fairly large number of inflammatory mediators are released, and this can, by the way, support the pain component during the wound. That is, if, for example, we have a cut wound on the first day, in the first hours and minutes without disturbing a person, then within 2 or 3 days, when septic inflammation begins, we suddenly begin to feel clear painful urges from the wound area, that is, inflammation is going on. On the 2nd or 3rd day, lymphocytes and macrophages appear in large numbers in the wound area. Prochollytic enzymes are isolated, phagocytosis of necrotic tissues is considered, plus neutrophils themselves as a result of what they do in most cases, sometimes die, and decaying neutrophils are also present earlier. That is, they participate directly in immune reactions. Well, pay attention, the phase of inflammation here, of course, is shown to be quite powerful, and in most cases it is already possible to talk about the attachment of the infectious principle directly to aseptically. The second phase during the Rodinoff process is regeneration, that is, healing. The whole thing begins with an understanding of collagenization, that is, the migration of fibroblasts in the wound area. Yes, and the synthesis of connective tissue components begins. That is, in essence, the wound begins to heal by forming connective tissue in the wound, that is, the construction of collagen elastic fibers. Plus, vessels begin to actively germinate into the wound. Yes, the growth of the vascular bed begins, or sewage. If it was a large vessel that moved to thrombosis in the wound area, then the blood flow through it, the body tries to restore. As a result, the so-called granulation tissue begins to grow in the wound. The tissue visually represents bright scarlet such bleeding papillae, that is, the same connective tissue that grows and, plus, blood in a wonderful way. The third phase is the phase of scar formation and reorganization, that is, the synthetic activity of fibroblasts gradually decreases, the amount of collagen does not increase, and the formation of transverse ligaments occurs between the newly formed collagen fibers. The strength of the clamp increases, that is, a scar and connective tissue begin to form, and gradually this scar begins to decrease. For him, the property is such a phenomenon as retraction, that is, its reduction. In parallel, the epidermis begins to grow directly from the edges of the wound, and we have epithelialization of the edges of the wound. That is, the underlying tissue heals by scarring, and the surface of the skin, yes, in this case, is covered anew with a new multilayered organizing epithelium, which we call the epidermis. Complication of the birth process. Well, in this case, you can highlight the early complications. We will analyze some of them in subsequent lectures. Let's assume a shock as a result of the fact that a wound, with all the desire, is a painful thing. Plus, with wounds, we said, bleeding is possible. This is the next early complication. Bleeding can lead to acute blood loss. If the loss is large enough, it can lead to post-hemorrhagic anemia, so-called. This is an early complication of the wound process. A late complication is an infectious complication. Well, in particular, this is suppuration of wounds, if we have the development of a nonspecific classical purulent infection in the wound. In addition, yes, that is, the development can develop into a general purulent infection. Yes, that is, it is a very dangerous systemic process which is called sepsis. A specific infection can get into the wound, tetanus, yes, that is, a radial specific infection. In addition, an anaerobic quadial non-specific infection may develop a process that was previously quite often called gas gangrene. With you at the last lecture of the semester, as I have already said, we will analyze the infectious healing of the wound process. That is, we will start with wounds, and we will end with wounds. Earlier, later secondary bleeding also refers to late releases of the wound. Yes, early bleeding, we will analyze it later in the next lecture, when we will analyze the bleeding. Factors affecting wound healing. Well, let's start in order. The age of the patient. It's no secret, but in childhood they heal much better and faster early than in the elderly. Well, this is due both to the peculiarities and regenerative capabilities of the body, and directly to the fact that the child's body is still in the growth stage and most tissues are initially programmed for the situation that they are actively, say, multiplying. That is, the state and nutrition of the body and body weight. That is, people with reduced nutrition heal much worse early in their lives. People with high nutrition, especially hypersthenics, that is, people with obesity, the same situation in this case sooner or later heal badly. The presence of a secondary infection earlier, that is, an infection that got earlier with all the desire leads to the fact that wounds heal with great difficulty, and often we have suppurated wounds heal already, so to speak, by secondary tension. We will talk about the healing features on the following slides. The immune status of the body. Citizens with a reduced immune status experience an increased risk of secondary infection of the wound and, as a result, worse prognoses in terms of the wound process. The state of blood circulation in the affected area and in the whole body. Yes? Well, let's talk first about blood circulation in the affected area. Let's say the same gunshot wound or, as we said at the very beginning of the lecture about wounds of a chopped and bruised nature. As a result of the fact that the microcirculatory bed around the wound is damaged, this leads to a violation of nutrition in this area. Such wounds heal much worse and take longer. In general, in the body. A simple example is diabetes mellitus, which is accompanied by a violation of microcirculation and a violation of nutrition in various areas, in particular in the skin, too. And, as a result, wounds in patients with diabetes mellitus heal worse. This can be discussed in the next paragraph, where chronic concomitant diseases are mentioned. With chronic concomitant diseases, well, whether it's the same diabetes mellitus or systemic diseases of the endocrine system, yes, or a disease accompanied by the development of chronic kidney failure, chronic liver failure. In this case, the wound process also takes place with a lot of, say, tension and heal worse early. Some types of therapy, well, in particular, patients who, say, are forced to constantly take glucocorticosteroids. In these patients, the wound healing process is much worse. Well, let's talk now about this very healing process. Yes, describing the last fight, we have slipped such a term as healing by primary or secondary tension. So, what is the concept of healing by primary tension? In this case, the statement occurs without inflammatory cooling, without suppuration, without the formation of visible, say, intermediate tissue, because in this case we will not say suppurated wounds, the edges of the wound are very actively treated and converge with each other, which is presented here, you see in the illustration. And subsequently, a linear small scar is formed. This occurs most often in wounds with even viable edges that lag behind each other by a very small distance, which allows them to be brought closer at a distance of no more than, say, 1 centimeter. And, of course, in the absence of wound infection. A typical example is the healing of, say, an operating wound. Yes, pay attention, the edges of the wound are exactly dissected, respectively, then brought together, sutured, That is, the edges are brought together with each other, and this allows you to form a completely small scar, and we are talking about the fact that the wound healed initially. Well, here is an example of a small scar after healing by primary tension on the forearm. Healing by secondary tension most often occurs through suppuration with the formation of visible connective tissue. Yes, that is, a large, huge conglomerate of emulation tissue is formed directly in it. Then we see that rough connective tissue begins to form there, and as a result, a rough scar is formed. It occurs with the development of a wound infection or in the presence of extensive tissue defects that are not, in this case, our integumentary tissues are not closed by, say, any surgical aids, or by plastic surgery. And, as a consequence, all this prevents, say, the primary comparison of the wound walls. Therefore, the wound is forced to heal by first forming a large volume of grafting tissue in it, then replacing it with connective tissue, and then the same retraction, when the walls of the wound are tightened, but are pulled together by a rough connective tissue scar. And this form of healing is called secondary tension healing. Well, you see, pay attention to what rough deforming, say unpleasant-looking scars. Here is another of the options, yes, with the formation of scars by secondary tension, which you see even the shape of the limb has changed. Another type of wound healing is wound healing under the scab. Occurs without scarring, and in this case one condition is that the wound must be superficial. That is, not only is it superficial, yes, we must damage, for example, the epidermis and, possibly, the upper layer of the dermis, but preserve the lateral layer of the skin. That is, the rapid regeneration of the epidermis occurs directly from this germinal layer, but most often under the corpse, under the crust which has formed on the surface of the rhoda. The scab is composed of fibrin and shaped blood elements that have dried up and baked on the so-called term. There is, yes, on the surface of the coca. In this article a classic example of a wound healing under a corpse is presented. Moreover, even the classics still lie in the antiseptic used. It is very typical for our country. Yes, mind you, it's diamond green. Literally 1 or 2 slides devoted to some terminological aspects. This is the moment you need to realize that there is a concept of granulation tissue which has already been said many times before. This is a special type of connective tissue formed during wound healing, mainly healing by secondary tension and contributing to the rapid closure of the wound defect. That is, if we consider the functions of the granulation tissue, it is the replacement of a wound defect, the protection of the wound from the penetration of microorganisms and ingress of foreign bodies, that is, it is the temporary performance of the integumentary functions just in the place where we have the defect of the absence of the epidermis. Yes, and an important option is also the sequestration and rejection of necrotic tissues. That is, the gutational tissue itself. It is not devoid of immune properties, because it is a fairly actively blood-supplied tissue. After that, the priming tissue, of course, is replaced by a coarser connective tissue and the whole thing turns into, well, then a few words about scarring and about scars. Scars are common, yes, it consists of normal connective tissue, has elasticity. For a while, it differs slightly in possible color, yes, but later it becomes so whitish. Here, pay attention to the upper slide, attention, a small absolutely scar on the first finger of the brush which is practically not noticeable. In addition, scars are hypertrophic, that is, they consist of dense fibrous tissue and are formed with excessive collagen synthesis. The usual hypertrophic scar corresponds to the boundaries of the previous wound, which was healed by secondary tension. That is, if we have seen an ordinary scar after primary tension, then a wound healing by secondary tension usually has a sufficiently voluminous hypertrophic scar. Or there is such an option as keloid scars. A keloid is a scar embedded in the surrounding normal tissue. The reason for the keloid formation is still unclear to this day, it is quite a separate big topic, but by themselves, keloids on scars, when they are formed, they not only, let's say, cosmetically injure a person, yes, but also keloid scar formation can lead to the development of contractures, that is, dysmorgenic contractures associated with the formation of scars on the skin. Complications, yes, scars, about whom, which is what we were just talking about. That is, a variant of scar contracture. Now only this has been described and, of course, it is clear that the scar formation directly in the joint area can tighten the skin together and, as a result, restricts movement in this joint. And this situation is called scar contracture. In addition, scars often, provided that it is a very dense connective tissue, are very poorly supplied with blood. There is practically no vascular scar inside the dense connective tissue as such. Therefore, trophic ulcers very often occur here against the background of this rough scar with ulceration of the scar itself. Due to the fact that the scar is poorly supplied with blood and when the human papillomatosis virus is attached, scar papillomatosis is very common. And there is also one of the options, provided that, again, poor blood supply, reduced antiviral and anti-tumor immunity, there is a tumor degeneration of scar tissue and modernization. That is, in the final we can get a malignant formation in the form, that is, in the place of formation. Well, let's move on to help with various forms of wounds, and a prerequisite is that you learn first aid to the wounded. Many of you will not become traumatologists, will not become surgeons. Yes, they will choose a therapeutic path for themselves and as such, in fact, they will not meet their wounds particularly. But the option of first aid in case of injury should be learned by everyone and be able to do it all. So, the main points that includes first aid. If we regard the wound as a violation of the integrity of the integumentary tissues, then, of course, the restoration of this integumentary barrier is the main goal. Therefore, the most important thing in providing first aid for wounds is mandatory. This is the restoration of the barrier by the local environment in the form of an aseptic sterile dressing. Other aspects of first aid in this case cannot be stipulated that they are mandatory. It is not always possible to treat the wound with antiseptics before applying an aseptic dressing. Yes, but if we have the opportunity, then such a situation is, of course, desirable. In the classroom, we will sort out, well, the option of regular laying in the first aid kit, but here it is worth mentioning that the classic example of antiseptics that are contained and must be in each laying is hydrogen peroxide, which is the first stage in the prevention of infectious complications, and this is chlorhexidine. Why these two drugs? They are cheap and therefore they can provide all the styling in the country. These are domestic drugs produced in our country by our pharmaceutical enterprises. These drugs do not require special storage conditions, that is, there is no obligation to keep them in the refrigerator or they're under some environments. For example, on a bottle of hydrogen peroxide, there are some, however, written off to +25, and some I meet where the storage conditions are from -50 to +50 degrees. Plus, not necessarily glass, that is, they live quietly in cheap plastic containers. Moreover, there are no such strict requirements as maintenance in vacuum, in ampoules, and so on. The next thing that needs to be done, for example, when providing first aid to a wounded person is the nuance of anesthesia. Again, the approach option is individual. Often a small incised wound and does not require any additional effects. If it causes some kind of pain syndrome, then it is quite tolerable, or in general, in principle, it may be insignificant. At the same time, massive large wounds, especially, say, even here we will have a separate lecture on burn wounds. That is, in this case, it is clearly necessary to talk about the need to prevent traumatic shock. Therefore, it is definitely worth mentioning the options for anesthesia that we will analyze when we give a lecture on shock. Another thing is that our access to painkillers is strictly limited. The ambulance has the whole set, and who will work on the ambulance will be able to apply narcotic analgesics and non-narcotic and parathyral anesthesia. Well, in this case, It will be correct to say analgesia and the option of recommendations in the oral form of taking painkillers. In most cases, we, as doctors, will not always have access to drugs. According to the indications, it is also necessary to talk about such types of assistance as immobilization of the limb. We have already talked about this with you, that, for example, a chopped wound, it often requires nuances of immobilization. About the implementation of techniques for temporary stopping of bleeding. This is the topic of our next lecture, but many wounds are still accompanied by bleeding, and here these techniques need to be able to perform, do and know. Separately, a few words on 3 aspects such as first aid for chest wounds. Moreover, with an injury with penetration into the pleural cavity and with a violation of its, say, vacuum in the pleural cavity, that is, as a consequence of a violation of the suction function, that is, with the development of pneumothorax. In this case, with an open pneumothorax, one of the mandatory conditions for first aid is an occlusal, that is, a sealing bandage. Well, in this case, polymer packaging from the dressing material is most often used, which is applied to the skin. Since it does not let in air and is turned inside out, it is sterile. And then the fixation is traditional, whether with a band-aid or a screw bandage. With penetrating wounds to the abdomen, that is, it is also necessary to specify certain points of the situation. That is, it is not just the use of an aseptic dressing, but here we need to remember that if we have a loss of organs from the abdominal cavity, they are not set back, that is, they are left in this position and the bandage is applied right on top of it all. In the presence of external bleeding, we have already said, there is a need to stop the bleeding, and the most common method, say, temporary stop of bleeding, is just the same ordinary bandage, but made in the style of a pressure hemostatic bandage. That is, we do not just use an aseptic dressing, but we perform it quite tightly, by bandaging, and this leads to a stop of bleeding. Primary surgical treatment, that is, wound-fo, is the main type of surgery that is used in traumatology and surgery, yes, when a person turns to you wounded for help. Moreover, it is performed at the stage of providing qualified assistance. That is, if these are outpatient conditions and trauma, in principle, such an injury can be treated on an outpatient basis. This is a trauma center or the emergency room of inpatient institutions. If this is a more serious injury, then it is, of course, an inpatient facility, but in this case it is quite possible to use the power of the operating unit, that is, with full anesthesia. So, there are 6 main stages of primary care, that is, primary surgical treatment, that is, this operation. You have dealt with them unambiguously on the cycle of operative surgery topographic anatomy. Let's do it again. I immediately stipulate in advance that these are surgical manipulations. If we consider FO as a full-fledged operation, of course, we need to say from the words of anesthesia, we were just talking about her. Outpatient conditions and minor trauma in the provision of care, whether in the emergency room or in the emergency room of the hospital, most often require local anesthesia with the use of local anesthetics. Believe me, many minor injuries do not require anesthesia at all. When you and I will carry out some of our effects on the body and on the wound to a minimum. At the same time, the most serious wounds, large, for example, gunshot wounds, which most of us will require general anesthesia, that is, anesthesia. That is, this option must be remembered, understood and known, depending on the pain syndrome that we will encounter. So, and the second thing that is needed is probably definitely worth saying that not all stages are mandatory when performing this operation. With many wounds, some stages are often not used, or even in principle, so it may be that most of what we will remember now, they may not be used. So, let's say the first stage is the dissection of the wound. Yes, that is, if you and I have a gunshot wound or a wound already infected initially, of course, this is an inevitable stage. We need to open wide, we need to find and review the whole situation in depth with the wound will ensure the fulfillment of many of the following stages. But if we have a cut wound, a wound that is really already gaping, it is already open and we can observe the entire wound together with its walls and bottom, then as such this stage may be absent. The second stage is the removal of people's bodies. Well, here, I think, it is also clear. Their presence suggests that they should be removed. In case of their absence, sometimes it is even stipulated by the mechanism early. Well, the same banal example we were talking about is a cut wound, right? Well, that is, they were cut with a knife. There physically cannot be any foreign bodies. Yes, in this case this stage may also be absent, but if we have the option of getting people's bodies directly into the wound, then, of course, they require removal. The third stage is excision of the inferior tissues. Here, of course, we will analyze this stage of the operation in detail in the classroom using the example of a gunshot wound. On the example of a wound in which a large volume of tissue around, let's say, the wound canal may not be viable. If we take a situation not as extreme as a gunshot wound, then, of course, the stage of excision of non-viable tissues is mainly used for a torn wound, when we have areas that are not supplied with blood, areas of the epidermis. And it often occurs with a bruised, namely with a multiplied wound. Yes, when, again, there are areas of skin that are already visually visible to her lower capacity. Deeper lying ones, well, in our case, of course, have the right to be excised. Most often it is fatty, subcutaneous fat, but the muscle tissue is incapacitated. It can occur in the wound in most cases only with a gunshot wound. In all other cases, damage to the feeding main vessels may be the cause of the lower capacity in the depth of the wound. The fourth stage is surgery on damaged organs and tissues. Well, this is exactly where we have the situation. For example, damage to the vessels of a major nature, of course, requires the work of a vascular surgeon to restore the integrity of the trunk. Damage to tendons and ligaments, yes, a traumatologist is required, who will make, well, in this case, a decision on performing either plastic surgery or suturing the damaged tendon. And in the case of bone, that is, the option of selecting the method of osteosynthesis. We have already dealt with this last semester. The fifth stage is a variant of wound drainage. Well, here it is necessary to say that infected wounds. It is mandatory that the wounds in which the infection has developed are drained, because the exudation that will begin to occur in the wound will require that this cord must be removed from the wound, otherwise the situation with infectious clearance will progress and in the final we can finish playing up to a generalized infection in the form of sepsis. Wounds suspected of an inflammatory process are also drained for prevention purposes, but in this case the drainage is not prolonged, it more often performs the function of even a diagnostic situation. If we do not see the exudate separation on subsequent dressings, of course, the drainage is removed. Wounds that are suspicious in terms of our such release as bleeding. Often they also have to be drained, because in the case of continued intra-wound bleeding with a previously tightly sewn, we will get a hematoma there in depth, and as a result, in the final, this blood will become inflamed, and we will get suppuration again. Therefore, even such, say, exudation, so hemorrhagically necessarily requires that it be removed from the wound itself. Well, the sixth stage with you and me, closing the wound, as you understand, is also not always feasible. We talked about the fact that bitten wounds are not always accepted to be sutured. Yes, gunshot wounds, and we sort this out in class. Initially, only wounds are sutured, for example, of the chest, penetrating the pleural cavity. There simply without this we will lose the patient from his motorax. And as far as possible, for example, with a gunshot wound, wounds of the face and genitals are sutured. And this is mainly related here in order to minimize the cosmetic defect as much as possible in the future. But this suturing is not as complete as with a normal wound. That is, it is not sewn on the head early. It is sutured early with leading seams, it is sutured early with provision seams. I think you have analyzed and passed such terms in general surgery. In all other cases, of course, the wound is mostly closed. Methods of wound closure, that is, suturing, whether using threads, or methods of, say, applying adhesive tape to the edges of the wound, we will analyze with you at the next piles. Plus, there will be quite a lot of video clips in this lecture, which I hope you will watch to the end and get into the essence. If you have to face such methods of wound closure in your life, you will not get lost. Secondary surgical treatment, in contrast to primary surgical treatment, is mainly performed due to the resulting complications. And most often, after all, it is either the development of a wound infection or the occurrence of secondary bleeding, when we have to go inside again, let's say, analyzing this wound in layers, that is, expand, find a bleeding site, stop this business. The next option, the aspect, yes, that I want to highlight when analyzing the primary surgical treatment. Well, let's talk here. That is, the pH of uranium is the main treatment for newly infected wounds. In modern conditions, when it is possible to use antibiotics in the provision of, say, pre-medical care, it is customary to classify primary surgical treatment like this. That is, within the first day we are talking about early primary surgical treatment. Most often, in this case, it will be too early to heal with primary tension in the future. That is, we will close it almost completely in cosmetic terms, or with insignificant amounts of drainage, and to a lesser extent it will be suspicious of us in terms of subsequent inflammation. In the period of 24-48 hours from the moment of injury. Often this FO is called delayed. Such wounds are already more suspicious in terms of the occurrence of inflammatory phenomena, or in terms of, meaning, infectious complications, infectious inflammation, or already have signs, that is, inflammation. Non-specific inflammation, let's say, the cause of which is the traditional nootrotic flora, that is, most often it is Staphylococcus, less often other microorganisms. We will talk about this at a lecture on infectious complications of wounds. Late surgical treatment is later than the second day, later than 48 hours. In this case, such wounds are most often already either conducted according to the principles of an infected purulent wound, but because most often by this time the wound has become inflamed, or we still have some difficulties with the last stage of the PHC, that is, with the closure of such a wound. That is, this case is carried out in stages with mandatory drainage of such a wound and with mandatory monitoring of the situation with inflammation. Indications of FO, all cases of injury, in any case. The purpose of primary surgical treatment in this case is the main goal, it is the prevention of suppuration. But the rest are for the purpose, this is with all the desire. That is, the main purpose of wound treatment is the restoration of the integumentary tissues. Well, the essence of the content of the FO is sanitation, sections of the infection zone, it's stopping bleeding, it's restoring the integrity of nerves, tendons, that is, everything. But what we talked about step by step in the last slide. The types of sutures are something else that needs to be said, of course, when we stipulate the last stage of the echo, that is, the closure of the wound. Primary suture. Most often, it is applied on the first day of injury, that is, when we are talking about early primary surgical treatment. Most often, this seam is completely tied, that is, it is a nodal seam, or any other options for applying the seam, which we will talk about a little later, and in most cases it closes tightly early. In case of suspicion in terms of our moments of accumulation of hemorrhagic exudate, that is, suspicion of not quite, say, satisfying hemostasis, you can leave a rubber graduate, and, say, in the nearest dressing then, with a positive effect, remove it from there. The primary delayed suture is performed on, in our case, the second day. And in this case, yes, our delayed emergency surgical treatment. And here, in most cases, we still leave drainage with you in some variant, but in most cases, the primary delayed suture is also tightened on the ear, that is, it is tied. Secondary seams. The secondary early suture is after 8 dashes for 14 days, and in most cases such a suture is used when we conduct the wound by the open method. That is, the same bitten wound, yes, well, about a gunshot wound, if it is not inflamed, does not fester, it is, of course, a rarity. We can also say that stitches will be applied to the wound, which we conducted in an open way, somewhere like on the 8th or 14th day. Secondary latals are most often a lot of infected and inflamed wounds that have experienced a period of suppuration, which usually lasts about 2 weeks on average if we fully brine the patient, and after that the wounds are closed with a secondary late suture. Well, let's try to talk in more detail about the 6th, probably, stage of primary surgical treatment, about closing the wound. Well, I analyze the amount of your knowledge that you received in the course of undergoing surgical cycles, in the process of studying topographic anatomy, operative surgery. Well, I probably come to the conclusion that you definitely should have such a video manual, repeat a little how it all happens. Here in this video you will be presented with the simplest of the options for, say, seams. This is a nodal seam applied to the skin, well, with the possibility of tying the thread directly on the needle holder. Pay attention to the nature of the actions. Everything is quite simple and convenient. At this wedding, you will be presented with another of the options, say, closing the wound. The method is called vertical mattress seam. What can you say about him? Well, the maximum is that this is quite a favorite seam of our esteemed Sergei Gennadievich Anaskin. In addition, this method allows you to reduce the edges of the wound in the case of a sufficiently powerful tension. When the wound is large, say, with its great depth, it gapes strongly and, say, there is a variant of stretching the edges of the wound. Or when the edges of the wound have been excised and we need to perform, say, a sufficiently large tension. Here is such a character which assumes a U-shaped seam, is called a mattress seam, or else they are referred to as a group of hypertractive seams. They allow, for example, to use a large thread tension and at the same time the thread will not cut through. And this seam is called a vertical mattress seam. Here, pay attention to how it is superimposed. The next type of seams that I would like to show you is a horizontal mattress seam. Well, pay attention, it is very similar to the previous one, only in itself the location of these U-shaped, say, views, well, or, as we say, the moments of the thread overlay, it is located in a different direction. It is also a hypertractive suture. Sometimes it is called a U-shaped seam, sometimes it is called a donate seam. The thing is quite simple, very convenient, and again allows for the possibility of application in cases where we have a large tension of the tissue and the edges of the wound when they are brought together, well, let's say, resist you and me. The next seam that I would like to show you is called simple in the English version, that is, a simple running lock seam, well, or we also call it a winding or continuous one. But in this case, it is the very feature of the word castle. The seam is quite rare, not often used, yes, especially on the skin, but very interesting. What's interesting here? It allows, well, firstly, to save time, definitely, when suturing long large wounds. Well, especially, of course, wounds still with a slight edge tension, that is, superficial wounds, mostly cut wounds. Wounds that do not require any great integrity in terms of their cosmetic stitching, but provided that one thread is used, practically not using scissors saves an extremely long time. Here, pay attention to how it is executed. There is a small nuance here, of course, which, well, in terms of practicing skills, requires trying to do it one or another time. But the seam itself is very interesting. Well, the last suture that I would like to show you is an intradermal suture which relates, well, to a greater extent to cosmetic surgery. It is these seams that are called cosmetic and they are used in this section of surgery. In this case, you will be shown a seam that is superimposed with absorbable skin material. Well, in this case, it is a synthetic monosyl type thread, judging by its color, that is, it is so light. This thread has an average resorption period, well, of the order of at least a month. Pay attention to how the wound suturing is performed in this case. The entire thread will be completely immersed directly into the wound there, and we will not have a thread on the surface and there will be practically no surgical manipulations with you, for example, related to additional skin defects that occur when stitching it with a needle. Well, let's say this is a rather intricate technique that requires the development of the skills of those who will still go to surgery. I think you will all master this technique. Well, pay attention to this method of closing the wound. That is, unlike the traditional nuances of using suture material, you can, in principle, try to close the wound using a band-aid. In our case, in our country, traditionally non-sterile adhesive plaster is often used, well, which, say, is cut in a certain shape in the form of, say, narrow strips and allows us to pull the edges of the wound. In fact, there are officially produced, so-called patch leather seams. Well, here is one example. This company Tri-M makes such a thing called a sterile strip, sterile adhesive strips. When are they applied? Mainly when closing small wounds, small cuts. Most often it is still a cut wound, when the edges of the wound do not dry up. And the faux itself is performed very quickly, for example, when we do not perform all the steps. Plus, a band-aid suture is most often still applied in such an anatomical zone that does not involve increased movements. That is, it is not a joint zone, it is not a zone, for example, of the face, where our facial muscles are very active. Sterile sutures are mainly, yes, thin sticky strips that are glued to the skin. Well, in this case, trim seams, where there is a neon thread inside. This makes it possible to strengthen this situation, the overlay technique you have just seen on this animation. That is, we apply stitches and tighten the edges of the wound, and plus the transverse fixing strip is glued. There are sterile seams with elastic properties. It is also quite a convenient situation when one edge is glued first, then the other is fastened, and due to this elasticity they tighten the edges of the wound to each other. Well, that is, a large variety of such variants of sterile adhesive plaster sutures. On the next piles we will see more complex structures that use the same method, yes, plastic fixation. Well, at this wedding, you are also presented with a very interesting adhesive plaster system presented by the firm Tri-M. It is, of course, more complex than just a variant of small adhesive strips. Well, please note, the nature of the actions is very logically and clearly numbered. A very interesting thing, well, let's say, resembling two occurring letters W and quite convenient in itself, here is such a design and technology of gluing the edges of the wound together. For example, the methods of applying adhesive plaster wound closure are presented to you here. This is the so-called dermaclip system. Well, let's just say this is know-how. This is a fairly modern thing, which, like any of the adhesive, say, techniques, assumes low invasiveness. That is, as such, we do not have additional needle punctures and suture material through the wound. It's not painful. In cosmetic terms, it gives a wonderful cosmetic effect. And as advertised by this case with any of the options for using adhesive systems, it does not require a repeat appearance to the doctor. This is the thing I would probably criticize in their advertising brochures. With all the desire, the doctor should control the moment of early healing, but definitely additional use of the capacities of dressing and operating rooms to remove such stitches, of course, is not required. They can be removed after healing even in non-standard conditions. Well, the last, probably, method for today, say, adhesive fixation and wound closure is the zip stitch system. It is presented to you here in the form of animation, so some way it may even be more clearly and clearly. Here, pay attention to such interesting plastic structures that can also be fixed on the wound. They can be quite long, just a certain set of such links comes off and after gluing, the fixation is stretched directly. Very similar to such plastic clamps. The next few slides we will have will be devoted to individual private variants of wounds, and I will not go into the essence of the issue in particular detail, but I will only highlight to you, probably, the main, say, dogmas in this situation, which relate specifically to a gunshot wound, to a mine explosive wound. We will analyze this case in more detail as part of your reports on the Report on Independent Work in Practical classes. And so, a gunshot wound. A gunshot wound is characterized by 3 typical damage zones. We talked about it at the beginning of our lecture, and this is a characteristic feature of a gunshot wound. The reason why we have not only a wound canal, which is characteristic, yes, any RODU, for example, for a puncture, yes, but also a zone of direct traumatic necrosis from a tissue injury, that is, from a contusion of a tissue wound, and a concussion zone, that is, a necrobiosis zone, or sometimes also called a zone of commotion. That is the concussion zone. An early projectile with a gunshot wound, well, whether it's a bullet or a fragment, flying at high speed, has a sufficiently large kinetic energy. If you remember a school physics course, then somewhere there you will remember the formula that E is equal to mb squared divided by 2. That is, we have, say, a bullet velocity factor directly in this formula. If you remember, the bullet inside, passing through our body with you, either slows down and leaving the body, we will have an entrance-exit hole and a through wound, or stops immediately earlier. Where does that E, that is, kinetic energy, go to us? Passing into the potential, it is directly given to the tissues that are located around the wound canal. And this energy has a damaging effect. It destroys, kills nearby tissues. That's why there are 3 zones in a gunshot wound, and the tissue damage spreads outwards beyond the wound canal. When using modern high-speed weapons, that is, if you take a long-barreled Kalashnikov assault rifle with a caliber of .545 with a very large, almost transonic bullet flight speed, then the diameter of this very damaging action exceeds the diameter of the wounding projectile, that is, 5 to 45 mm by 30, or even often 40 times. Such a large diameter around the wound canal can die. And in this case, when performing our primary surgical treatment, yes, the main and most effective measure that creates favorable conditions for wound healing is precisely high-quality primary surgical treatment. At that stage, which consists in excision of non-viable tissues, we often have to excise a very large volume of soft tissues. We will list with you once again the stages of primary surgical treatment, but directly applied to a gunshot wound. Well, let's say, for example, a gunshot wound of the shoulder with marginal damage to the humerus. So, here we go. After high-quality anesthesia, well, in this case, most likely it is general anesthesia. That is, we make a toilet of the surgical field around the wound, we dry up the non-viable necrotic edges of the wound. Let's do this, we're treating within a healthy tissue of 0 to 5 centimeters. If we are going to look at the skin now, then the skin will often be very difficult to replace in the future. That is, if we try to pull on nearby tissues, even using hypertractive sutures, we will still not be able to pull off a large, let's say, diameter of the damaged skin. Even when using special techniques, by, let's say, a Z-shaped skin section, a Y-shaped and, say, a geometric rearrangement of leather shanks. We, with all our desire, will need a skin transplant, so the skin is spared. The skin tries to dry up very sparingly, within, I say again, 0.5 centimeters of healthy tissue. In military field surgery there is such a term. It is not necessary to cut nickels. Well, you understand. The next step is to dissect the wound widely along the course of the wound canal, yes, from the side of the inlet and outlet openings. What will such a wide dissection allow us? A qualitative review in the wound. We have to do a very thorough viability assessment. Therefore, a visual overview earlier is very necessary for us. The faces are dissected Z-shaped, they are spared. This is a tissue that tolerates ischemia very well and often retains viability. I mean fascia, aponeurosis, subcutaneous fat. In the course of how we get to the fascia, in principle, can be excised very radically. Subcutaneous fat is not the most necessary organ for us, and its excision will not affect the subsequent healing in any way. So, during the wound process, we need to carefully perform hemostasis. Therefore, the ligation of bleeding vessels, small vessels are coagulated, more than an average diameter is ligated, that is, by ligation. Well, as you understand, if we get a major vessel in the depth of the wound, we will have to perform, say, vascular surgery techniques. Both large vessels and large nerves definitely need to be preserved. If they are damaged, perform their suturing, that is, stitch the edges of the wound, or vascular suture may be accompanied by an overlay even for neuroses. In the course of the country's work, we may encounter foreign bodies, pieces of clothing, fragments of a wounding projectile and, say, those things, the earth that can get into the wound. All this will have to be removed from the wound there, that is, foreign bodies will be removed. Surgical treatment of marginal bone damage. Well, as we assumed in our case, there is damage to the humerus, so the treatment of the edges of the damaged bone, the removal of, say, non-viable free bone fragments. In the process of our excision of the non-viable edges of the wound, we have already talked about the large probable diameter of the soft tissue damage caused by a firearm shell. Therefore, in the process of our wound revision with you, it is very carefully worth approaching the viability assessment, and any devitalized tissues should be removed. Muscle tissue, which is dangerous in terms of suppuration, should be evaluated during our operation. This is the most difficult part of the operation. It requires experience in understanding a gunshot wound. That is, to excise muscle tissue as radically as possible, but at the same time without abusing it, because we will need muscle tissue. After the healing of the gunshot wound, the muscle tissue will not be replenished. It will be replaced by connective tissue, one that will not have the function of contraction. Therefore, with all the desire, the muscles must of course be spared, but any necrotic component remaining in the past will give us suppuration, and in the final it may end badly. Therefore, I say again, it is very difficult with radical excision of muscle tissue to understand and realize how much this tissue is devitalized, incapacitated, and requires excision. The next stage will already be the final stages of the operation, that is, abundant washing of the wound with antiseptics, possibly infiltration of the wound edges with antibiotics. Yes, drainage is a mandatory situation in which the drainage of a gunshot wound is performed. Moreover, drainage is often installed both directly from the inlet and outlet openings, and from the counterpurchase. For a gunshot wound, a drainage tube is used with a very large diameter, more than 1 centimeter. Why is this done? Based on the paradigm that a gunshot wound is almost always inflated and in the process of separating the exudate, it is not a fact that the exudate will be liquid. It is quite possible that fragments of necrotized, say, soft tissues will be included. Therefore, the tube must be at least 1 centimeter in diameter. It is not sutured early, it is loosely tamponed early, and tampons often need to be impregnated with an antiseptic. Yes, an aseptic bandage is applied on top. Primary seams are not applied. It is possible to apply suggestive sutures, that is, without tying, or provision sutures, that is, by tying on a bow, which can then be in the process of second hand, that is, in the process of repeated observation of the wound. They are opened, untied, and it will be possible to look into the wound when performing dressings, or even when performing secondary surgical processing. So, these types of stitches are applied only in the area of the face and in the area of the genitals, and then in order to, somehow reduce the area at the time of the cosmetic defect in the future. Well, in our case, given the damage to the bone apparatus, definitely after we leave the wound open, but still cover it with a bandage and tampons, the limb should be immobilized. That's how difficult the approach to primary surgical treatment is clearly different in itself, and that's what a gunshot wound looks like during treatment. Well, another type of gunshot wound, unfortunately, is a mine explosive injury. A mine explosive wound is the result of exposure to an explosive munition on the body. Why did I say the word unfortunately? Because, for example, a mine explosion injury is probably one of the main components of a terrorist act, which in itself is a social problem. Terrorism has been bothering our country and the whole world for many years. When an explosive munition explodes, several damaging factors affect the human body. That is, not only the early projectile itself, but also the shock wave. Also, if the wounded person is directly in the vicinity of the explosion, we can assume that a fire factor will act on the person, that is, high temperature and flame. In addition, the products of explosives, that is, the explosive itself, getting into our body is far from a harmless substance. Almost all explosives are highly toxic. Toxic products that get into the wound not only will hinder the quality and proper healing of our wound, poisoning it locally, but also affect the entire body to the fullest. The facet process of variable explosive wounds and has a number of features. Let's fill in the basic ones after all. So, mine explosive trauma is often accompanied by acute massive blood loss. Considering the impact of the shock wave, mine blast trauma is very often combined with a bruised heart, that is, a closed chest injury accompanied by a bruised heart and a bruised lung, but in particular it is even quite often accompanied by a traumatic brain injury. That is, the injury is of a combined nature. We damage not only the skin and integumentary tissues in the form of wounds, we can often have damage to various organs and systems. Given the large and massive nature of soft tissue damage, very often a mine blast injury is accompanied by the development of traumatic illness and traumatic toxicosis. A very large volume of necrotic tissues manages to suck into our body. Plus, in addition to traumatic toxicosis, we have already said, toxic products left in the wound can be added just initially, well, let's say toxicosis. The wound is of a combined nature, that is, such an injury. We have already said that in addition to mechanical effects on the body, yes, we have both toxic and thermal effects in the case of flame exposure. Well, these are the features of a mine explosive injury. This is an extremely severe form of traumatic pathology. At the next wedding, you will be presented with a video clip of the operation. Moreover, let's just say that this video itself is quite old and ancient. It was recorded, let's say, during the Afghan War. It was not made by our domestic side. This is part of a large video recorded by Red Cross staff, and it tells exactly about military field surgery, and in particular you will be shown exactly the treatment of a gunshot wound and focused attention on the main points of primary surgical treatment of a gunshot wound.
However, the most dangerous is the wound on the buttock area. She is infected with a significant purulent discharge. The posterior surface of the thigh is severely damaged, and there are also terrible-looking penetrating wounds on the posterior surface of the lower leg. The principle of surgical wound treatment is to excise dead tissues, as well as in an effort to preserve as large an area of the skin as possible. Excision of the forearm wound is performed. Particles of earth and explosives were found inside the wound. Excise all dead and significantly damaged tissues. Military field surgery in those conditions when patients arrive at a late date is the surgery of contaminated and infected wounds. The damaged area of the skin on the front surface of the lower leg must be excised down to healthy tissues. Subsequently, it is necessary to perform skin grafting. In this case, the patient needs to perform amputation below the knee joint within healthy tissues with the expiration of all dead and infected tissues. All the stitches on the early scrotum were removed and earth particles were found inside the testicle. The wound in the buttock area was sutured, but it became infected. Purulent discharge appeared, which can lead to death. The wound in the depth is contaminated, there are particles of explosive and dead muscle tissue. Surgical treatment consists in excision of all these contaminated and dead tissues. The principle of military field surgery is to make a wide excision of all dead tissues, leaving the wounds open afterwards. Leave the wounds open.
Well, with that, let me finish our first lecture this semester. Thank you for your attention.